Hey, well, good afternoon, everyone. Thank you so much for being here. We're in for a special treat. We have Dr. Darren Nicely here to talk to us about our Vinci robot. Without further ado, please welcome Dr. Nicely.
Thank you. Thank you all so much for being here and just for the support of us and of the program and of our community. We're all really excited about this. And so hopefully I can answer some questions. I know it can sound a little mysterious. You know, it's all behind closed doors and this, sterile place. But we'll bring some pictures to you, and maybe at some point we can even set it up so that people can come and look at the robot, because it is some pretty great technology. I've got just a brief outline here for you of what my goal is today and what we're going to cover. I do have a few disclosures. Just listed here on the side. I think that this is an important way to sort of frame the talk. I did produce this presentation. It wasn't given to me by Intuitive or by anybody else. I put the slides together so the views express their mind, although I do hopefully present you with some convincing information and research regarding the robot and its use. The patient pictures in the slideshow are public domain, in case anybody's worried that I'm taking pictures in the OR and then showing them to the community. And I don't have any financial relationships with Intuitive. This is my wife, Melody, and our three girls. And they're the love of my life. And I drive up here from Grand Junction. Thank you so much, I appreciate that. Drive up here from Grand Junction along with a handful of my partners, and we provide the surgery services for Grand River. So yeah, it's been a great relationship, and one that we're excited to continue. I do have some notes here. I'll apologize, I didn't have time to kind of memorize my whole speech, but I'll be referring to them and kind of trying to keep myself on track and on time. So forgive me if I'm looking down here to reference them frequently. So this is the question that kind of comes up over and over again, and really even since its inception, is the big question, is why do we have robots? Why do we need robotics in surgery? And my goal by the end of the presentation is really to make so that all of you can answer that question, at least to some degree. My first argument for robotics is that we live in a changing environment. So, the field of medicine and surgery is no different. This is one of the earliest known procedures. This is known as trepanation. I don't think it was always used in the correct way. We make burr holes in neurosurgery for people who have increased intracranial pressure, and to relieve pressure on the head and in the brain. But this was actually a cure that was touted for madness, as a cure for madness and for mental disorders. So I don't know what the significance is of the funnel or the book on the head, but I think we've come a long way from that. Back to 7,000 BC, as we have evidence of this happening. And I'm sure it was cutting edge at the time, but I also think you'd probably go to jail if you did this now. So now this is the 1800s, and we've made a couple improvements. We're now indoors instead of in a meadow. But otherwise, the patient's still awake, in some distress here. And I think sterile technique is far from anyone's mind. And then, we jump forward to the mid-1800s. This is the ether dome. So big improvements. We've got lots of glass overhead, which you can't see. That's why it was called the dome, the ether dome. It let in lots of sunlight so they could operate. And what you'll notice there is the patient is actually asleep. So they're using ether to anesthetize the patient. And now they can do a lot more procedures without squirming and wriggling. And I think as I was looking at this this picture, Dr. Coleman's not here to defend himself, but I think he's in third row. So now this is laparoscopic surgery, and this is a big step forward. But this really revolutionized how surgery was done in the early 1990s. There was some application of laparoscopic surgery in the late 80s, but really the 90s is when it took off, and there were broad applications to a lot of other procedures. The advantages were smaller incisions, and that translates to faster recovery time, less pain, more surgeries could be done outpatient. And then, of course, as it relates to me as a general surgeon, that means fewer and less incisional hernias. And we'll come back to the importance of that later in the talk as well. So the benefit to patients is really huge. There were a few major drawbacks with this type of surgery. As you'll see, all of these instruments that are being used are what we call straight sticks. And there's a jaw on the end, and you can put a lot of different things on that jaw: graspers, needle drivers, energy devices. But really all you can do with that is just open and close. There's no articulation, there's no wrist. And so laparoscopic surgeons have to learn how to translate a 3D environment into sort of more of like a 2D type of a procedure. And the screens are also two-dimensional. So this is all two-dimensional surgery. In spite of that, because of the huge benefit to patients, it was adopted really broadly. The issue was that it again kind of hit a ceiling with improvements. And what's interesting is that we really are using a lot of the same instruments that we used 30 years ago when they were invented. And, HD monitors and cameras have gotten better, but it sort of hit a ceiling on what can be done. So then, introduce Da Vinci 5, and this is, it looks a bit futuristic here, but these pictures are right off the website. This is real. This is exactly what it looks like. And while there's some really amazing new features on this latest version, this too has actually been around for a while. So this got its first FDA approval for soft tissue surgery in 1999. So that's 26 years for anyone struggling with the math. And what that means is that it's a company that's been working with surgeons for a long time to improve and to make it more applicable and relevant. And I can attest that in the 10 years that I've used this in surgery, that it has made big improvements. There's the machine and the capabilities of the platform. Kind of looks like a little cross between Wall-E and Eva for you Wall-E fans. So this is always, another kind of common question is, how does it actually work? And, patients often wonder, well, what's going to, are you still in charge? I don't know if I want a robot doing my surgery. And so one big thing to emphasize is this is not an autonomous machine. The surgeon is in charge. The surgeon sits at the console and utilizing hand controls, foot pedals, operates with the face in a 3D viewer. So it's 3D, it's 10x magnification, and as you operate, then the robotic portion of the robot translates your movements to the patient tower, which is all the way there on the right. And you can see that there's 4 arms there. So the surgeon starts at the patient bedside. Patient is prepped and draped. You safely get into the abdomen, insufflate with CO2 gas that creates the working space. And then ports are placed across the abdominal wall. And what that is just a little cylinder, basically, that traverses the abdominal wall. And through that cylinder, then you can put a camera to see inside. You can put in laparoscopic arms. And really, robotic surgery is just advanced laparoscopy. So it works in a lot of the same way as laparoscopic surgery. And then once those robotic arms are attached to the ports, then the surgeon goes, to the console and has that, those benefits of the 3D visualization. There's always a tech at the bedside to help with instrument exchanges and, just kind of monitor the patient and make sure that they're safe. There's a lot of 40 different wristed instruments now on this machine. So right away you can see, when you can roll your wrist, that it totally changes what you can do. And we have needle drivers and clip appliers and suction irrigators, energy devices. And this really, we compare it a lot to laparoscopic surgery because it is, but it much more closely translates from an open procedure, which is amazing for people who are learning and also just in sort of how you approach the case. every one of us who operates, whether or not they'll admit it, has some tremor just to being alive and having a pulse. So this does also eliminate that tremor. So some of the Da Vinci 5, improvements that we're getting just on this machine, which are exciting, are, for a long time, we did not have any force feedback on the machine. And the magnification and the 3D vision was so good that after operating with it for a period of time, you really would believe, you would say, I can feel that. But you really can't feel it at all. It's just that the way the tissue behaves and responds and the visual feedback that you get as you operate sort of tricks your brain into thinking that you're feeling. But you can't until now. And with some force feedback, the platform does generate a little less stress on the tissue. We'll see how that translates. But it's an exciting thing to see, especially in kind of delicate operations. Let's see where we're at here. The other thing that the Da Vinci 5 has is a more efficient layout. So it's really, one of the things that has come up over and over with robotics is that it takes longer. That's a big argument from people who are not excited about it, is that it takes longer. But this really does, the efficiency of the new machine should help to solve some of that. And then, as we'll discuss later as well, time in the OR is not always the most important metric. Sometimes you take a little extra time in the OR and then you have a shorter hospital stay or less complications, and that becomes a more important concept. So this is, we're going to get into a couple of the procedures that we do and what we can do with the machine. The inguinal hernia repair, this is kind of bread and butter, abdominal surgery. It's really would be hard to talk about general surgery without talking about hernia repair. I still, on open unilateral inguinal hernias in a young person without obesity, will offer them an open approach. I think it works just fine. It's been around a long time. In some applications, in some settings, it actually works better for the patient. And that's really one of those things that's been perfected over decades. So we'll still offer it. But there's times when the robot really does have advantages. And here are two examples. The one on the left is a bilateral inguinal hernia. So this patient has a hernia on both sides. And the one on the right is a previous open plug and patch repair. And so you see the plug kind of sticking through down there and it's failed. You can see the recurrence underneath there through the indirect inguinal space. But there's 3 spaces in the inguinal canal that can potentially develop a hernia. And when you do this robotically, what you do is you take down, you enter the abdomen, looking down in the pelvis, you take down a flap of peritoneum here. This all comes down. And then you broadly cover this whole space with mesh. And those are about the size of my whole hand, fingers included, each of those meshes. And we overlap them in the middle by a couple centimeters. And then you reapproximate that peritoneal flap. And it effectively keeps that foreign body out of the abdomen so it doesn't stick to bowels. And it's a really good repair. So recurrences, we want to approach that in a fresh plane instead of going back through old scar tissue. So there's less issues with injury and complications doing a new tissue plane. And then, bilaterally, we make the same 3 little incisions across the belly, whether we're doing one side or 2, and the port placement doesn't really change. So there's no really additional incisional consequence to doing both sides. And that's a nice way to do that. This is another really common application in general surgery, and that one that really has some really important implications for patients. One of the specific strengths of the robot is working in tight spaces, and the pelvis is one of those places. So, in patients who have rectal cancer or diverticular disease, this really stands out. And we know that robotic surgery in colon and rectal surgery leads to shorter hospital stay and fewer conversions to open. This is comparing to laparoscopic. So fewer conversions to an open repair, less sexual dysfunction when you're working deep in the pelvis around those nerves, and then lower rates of local recurrence. And that is huge. So this just was published in JAMA back in June of this year. This is a huge study. This is randomized controlled trial. So level 1 evidence, this is as good as it gets. And when they compared the 3-year local regional recurrence for mid to low rectal cancers in patients operated on for rectal cancer with the robot versus laparoscopic, there was half of the recurrences occurred in the robotic surgery that did in the laparoscopic surgery. And it's not because their surgeons weren't good at laparoscopic surgery. These were colorectal surgeons who are career surgeons. And 4% is actually comparable to open as well. So when you look at sort of what I guess you could call as the standard or the expectation of 4%, the robotic cuts that in half. So this is really huge. Another thing, kind of hopping back again, to just colon surgery in general, right hemicolectomy, left, maybe not working so deep in the pelvis, but I just want to emphasize is the fewer conversions to open. This is a really typical port setup for my robotic hemicolectomy. You've got a series of small incisions, and then you got to get the thing out at the end of the case, but you can make that incision wherever you want. And we know that the incision with the lowest hernia occurrence is a low fan and steel incision, kind of like what they use for C-section. So that's what you can see there on the left of the screen, is this short little incision, just big enough to get the colon out. You can't do a lot through that incision operatively, but it's big enough to get the specimen out, and then has a much lower chance of developing a hernia through that spot. So when we convert to an open surgery, this is the kind of scar we're talking about, to be able to get in and to be able to see what's going on inside. You can't make that teeny little incision down here when you convert. You just got to open it up, and that has big implications for people, especially in a population that is dealing with more diverticulitis at younger ages, more colon cancer at younger ages, a population where we're struggling with increased rates of obesity. These incisional hernias, there's a lot of downstream effects to this. It's not just the longer hospital stay for that patient, but it's a lifetime of, increased adhesions and bowel obstructions and hernias. So this is sort of another, common picture from the operating room. I kind of explain this whole idea of, heavier patients having an increased risk of incisional hernias. But because we practice broad spectrum general surgery here in our group and on the Western Slope, it's not compartmentalized into general general who deals with hernias, and then your hernia expert, and then your colorectal expert, and we kind of have to deal with all of this. So we see these people back, and there's not a lot of really meaningful data showing robotics versus open or laparoscopic on hernia repair. And I think the issue is that we're really not comparing apples to apples a lot of times. There are so many factors: hernia size, you have patient size, patient risk factors, technique, type of mesh, location of mesh, and really the list goes on. So when you're trying to compare, two different techniques, number one is just recruiting patients to the study is difficult and takes a long time. And a lot of times what happens during the course of a study is that surgeon techniques even change. And so that we just don't have good evidence. But what you do know that happens to be shown consistently in the literature that we have is that there's a shorter hospital stay when we repair them robotically. And I think the other thing that most of us would agree on as surgeons is that the retrorectus placement of the mesh probably has the least recurrences. So in a patient who's appropriate for that surgery, doing it robotically is really kind of my favorite way of doing it, and I think is the best way of fixing these. This is just a picture of a complex defect to repair. This is probably something in the range of 12 to 15 centimeters in diameter. And as you can see, you always have sort of on these big incisional hernias, you always have kind of your primary defect. And then when you look, up and down the midline where that incision was, you can see areas of weakness. So, even in patients who have very small incisional defects, if they had a big incision, I always tell them, robotics still might be better for you because you've got one bulge here now. We can go in there, we can make an incision over top, push it down, put in a little piece of mesh. But eventually we're kind of playing whack-a-mole because, we'll fix that and then another one will pop up above or below. And then we're needing to deal with that problem too. So the robot just gives you, the entire visualization of the abdominal wall and a place to put your mesh. And then, some, questions are just have self-evident answers. This is a component separation depicted on the left side, done open. And, this is what they go home with. And this is a very common setup for how I repair these robotically. Sometimes if we're doing a bilateral release, I'll have to, double dock and put this same set of 3 on the other side to come this way, but still 6 little incisions, 8 millimeter incisions versus getting kind of unzipped and filleted open. It's not a hard choice. So it would be hard for me to talk about general surgery without touching at least a little bit on cholecystectomy. This is the most common operation that general surgeons do. I can't say that I'm super excited about that. I do them. Maybe that's all I should say. It's just one of those kind of, it can take 15 minutes or it can take, 150 minutes. And you don't always know when you go to the OR what you're going to get. The longer the patient has had symptoms and the longer they've had acute cholecystitis, the higher chance of complications you're going to have. But it's just one of those cases that everybody sort of just expects, I'm just getting my gallbladder out. And, nobody really thinks about how significant this case can be. What we do know, once again, about robotics is there's lower conversion rates to open. And from personal experience, I can tell you when I find a complicated issue robotically, I really like to be able to just fix that right away instead of needing to convert. I've fixed fistulas to the colon, from the gallbladder to the colon. Just last week I did that, to the duodenum. I found little accessory ducts called ducts of Luschka coming high off the liver bed where they're not supposed to be into the gallbladder. And when you find those and deal with them right away, then you spare your patient a lot of issues down the road as well. This is just a depiction of us using indocyanine green, which is a really cool technology, the fun pictures to look at. This actually has been around for a while in laparoscopic surgery as well, but it's very commonly used in robotics. And what you have is a tracer that gets administered in the IV, gets metabolized by the liver, and then excreted into the bile. So everything that has bile glows green. And you can really see here the critical structures. This is sort of a simple cholecystectomy, you could say. So the anatomy is already kind of clear, but if you're sort of, pawing through a bunch of red and nothing really is making sense, this green illumination of the common bile duct, that's this right here, and the cystic duct coming off of here is really, really helpful for defining anatomy. This is another application of the ICG, just working the pelvis. These are the ureters down the side here. And so, if you're working in a really inflamed field, you inject some ICG in the ureter and suddenly can see pretty well. I kind of bring this up last because I think as surgeons, it's not the most important thing, but I do think it is an important thing. And I think that when we talk about the impact of laparoscopic surgery on surgeons in general and on a career, this becomes a very important point. Surgeons who do a lot of laparoscopic surgery have pain, neck pain, hand pain, because it's physically demanding. You end up, kind of twisting your body in unusual ways, and even if you're not thinking about it, to try to reach something or hold something. for long periods of time, it really translates over a career to years lost because of people retiring from pain. And robotically, that just doesn't happen. We've got the fourth arm you can retract for yourself. It is just much less frustrating and physically demanding. So I think it's an important point to bring up as well. As far as just the Da Vinci 5 that we have here, Intuitive's a company that has really demonstrated its commitment to developing its products and working with surgeons and continuing to grow their robots and their program. And some of the really cool things that they're working on, but maybe are not quite rolled out yet, are showing a lot of videos to artificial intelligence, and then teaching the AI, where are the critical structures, where should you not dissect, where are you close to being in trouble. And this is something actually that in the lab I think they have already, but you could some sort of technology to help provide warnings and anticipate errors, which could be really cool. This is something they're doing now, is analyzing surgeon efficiency. Really every detail of the case can be analyzed. It's objective data. How efficient are your movements? How many instrument exchanges do you have? How long does it take you? Et cetera, et cetera. And then this telepresence is something you could schedule somebody to kind of, watch in the OR and provide pointers. Somebody who maybe does, 10 of some case a week that you do maybe once a month. And so that could be helpful. And then of course the whole idea of robotics initially, very, very initially, was maybe being able to do some remote surgery, and the practicality of that it hasn't necessarily always played out, but the company is very forward thinking, and that is helpful to us as surgeons. These are opportunities for growth here at Grand River. Urology uses these for prostatectomies, other cases in the pelvis, and then obviously gynecology is in the pelvis too. So this is a service line that really can expand and grow as well. I think most of you will know our faces. That's Dr. Nana there on the left. There's me. There's Dr. O'Day. The three of us and Dr. Anderson are really hoping to be here a lot more. One of us hopefully all the time. So, 3 of 4 of us are using the robot. Dr. O uses the robot in her cases, and of course Dr. Van Essen too. So, we're all in the same group, and this is a technology that we're all really comfortable with and use every day in our practice. This is right off the Grand River Health website. And, I think it's safe to say that bringing a robot to Grand River really aligns with and supports all of these goals. So we come back full circle to this question of why robotics. And I'm just going to go ahead and say that if anyone's still struggling with the answer to this question, I might know a guy who can help. Thanks so much for your time.